We'll move on to our next talk. It's actually a recorded talk by Dr. Milani. It was prepared a couple of weeks ago in anticipation of him not being able to be here. So if we can start the recording for Dr. Milani addressing the issue of what do I do if initial therapy for AL amyloidosis doesn't work?
This talk. I'm really sorry that I'm not able to be with you in person today, and I'm really grateful to Professor Zonder, Silva, and the organizer for the possibility to record this talk, and that I will try to join you online today. We have to talk about what to do if initial therapy in AL amyloidosis does not work, and those are my disclosures. So I will start with a really simple case. We had a 62-year-old woman with AL lambda amyloidosis with cardiac and renal involvement diagnosed here in Pavia in 2019. As we see, she had a stage 2 cardiac involvement and also, according to the Mayo classification, and a stage 2 renal involvement according to the ISA renal stage. We decided to start this patient with cyclophosphamide, bortezomib, and dexamethasone, and unfortunately she did not obtain a reduction in the free light chain concentration. So we directly decided to move on an autologous stem cell transplant. We performed an autologous stem cell transplant with melphalan 200, and unfortunately there was no reduction in the free light chain. And also we observed a progression in terms of renal dysfunction. So my question is what to do now in this patient. Those are possible options. So we can move to lenalidomide and dexamethasone. We may perform a second autologous stem cell transplant. We can decide to resume bortezomib and dexamethasone, or we may try to use a daratumumab containing regimen. Unfortunately, I can't see your answer, but I think that this easy question can be answered with the use of a daratumumab containing regimen. So the first question is when to start a second regimen, second or a third regimen in a patient that do not reach an hematologic response. But the big question is when we should reinitiate treatment in a patient that obtain response to first line. For this question, there is no consensus among the experts. We asked with my mentor, Professor Dispensieri, a few years ago to 50 physicians when to start the second-line option, and there was no agreement among all the experts, but they proposed different cutoff of the FLC or others. We know that hematologic progression usually precedes organ progression several months, and so that we do not have to wait for having organ progression to start a subsequent line of therapy. In both those studies, one from the Mayo and one from our group, in rescue treatment was started before the so-called hematologic progression criteria that are still the ISA criteria from 2005. Now we have several treatment options. Treatments against the plasma cell-directed therapies. For example, we have second and third line immunomodulatory agents. We have new proteasome inhibitors. We have the old alkylating agents that still could play a role in relapsed refractory disease. Unfortunately, the development of melflufen was recently stopped. And we have now monoclonal antibodies. We heard before about in the previous presentation, of course, about daratumumab first line, but it plays an important role in second and subsequent line of therapy. But also we have other monoclonal antibodies, and we have other drugs in development. On the other hand, we have also fibril-directed therapies, and we will discuss about doxycycline and other anti-amyloid immunotherapies. And also, we will just touch base about the light chain stabilizers development. So, looking at those options, immunomodulatory agents, in particular lenalidomide, plays an important role for second line in AL amyloidosis. It resulted effective after alkylators or proteasome inhibitors. I would like just to remember that the maximum tolerated dose is 50 milligrams per day, and also that we have to be cautious in patients with renal dysfunction, in particularly those with elevated proteinuria due to possible renal toxicity. Pomalidomide may be slightly better tolerated and also resulted really effective in previously heavily pretreated population. As I said, Daratumumab has now an important role first line, but it plays in all those patients that did not receive Daratumumab, it plays a really important role in subsequent lines of therapy. In several studies, phase 2 clinical trials, but also many retrospective series, it resulted in rapid and profound hematologic responses. Also, it was noted high organ responses, also good quality of organ responses. And so this drug really is playing an important role in this setting. In this meeting, it will be discussing the poster session about the use of Daratumumab in subcutaneous infusion. And also, we have to wait in the upcoming months the results of the ongoing clinical trials regarding the combination of Daratumumab plus pomalidomide that was not explored previously, and is exploring in those clinical trials. In the previous studies, Daratumumab was combined with both bortezomib or lenalidomide. Moving to other treatment options, ixazomib resulted effective in relapsed refractory disease, but in these important studies published last year by my mentor, Professor Dispensieri, it failed to reach the endpoint, and it failed to reach the higher overall hematologic response rate compared to the so-called physician best choice that I remember that was lenalidomide-based regimen in the majority of patients. A higher cardiac and renal response was noted in the treatment arm, and also a non-significant trend in a better complete response was noted. The authors also reported a longer progression-free survival in the cohort of patients treated with ixazomib. So this drug could probably still have a role in AL amyloidosis. Carfilzomib is another important proteasome inhibitor, but as we know, it is associated with the possible cardiac toxicity. So it has to be used with a really caution in patients with cardiac involvement in particular, so probably only for highly selected patient population. Another old drug that could play an important role is Bendamasting. Two retrospective series, one from our group in collaboration with the German researcher and one from the London group, reported good hematologic responses with the use of Bendamasting in heavily pretreated patient population. And last year, they were presented by published the results of a phase 2 clinical trial from the colleagues from the Memorial Sloan Kettering. So probably the use of this drug could still be considered, in particularly for those patients with the IgM AL amyloidosis, maybe in combination with rituximab. Moving to other possible treatment options, Venetoclax was explored in a in a couple of studies. The bigger studies was an important international collaboration that reported that was published this year, In this study, it resulted that the Venetoclax is an effective drug, in particular as expected in those patients harboring the translocation 11-14. So the role of this drug has to be explored in AL amyloidosis, and the clinical trial is underway. Another possible option, another possible new drug is belantamab mafodotin. At this meeting, it will be presented a poster regarding the use of this drug in a small case series with interesting results. And of course, we have to wait the results of the ongoing phase 2 clinical trial that is underway here in Europe under the European Myeloma Network group. So those are really new possible options that has to be explored in AL amyloidosis. Moving to the so-called antifibrillar therapies, the first one that I would like to discuss is Scale 101, that was extensively presented in the previous ASH meetings and also will be discussed at this meeting in an oral session. The results from the phase 1 study were really good, with a 63% of evidence of organ response. And also, the results of the phase 2 study recently published in Blood are important and also will be discussed at this meeting. So this antibody it will be evaluated in a phase 3 clinical trial that will start soon also in Europe. And so the results of this important phase 3 study are largely awaited in order to confirm the role of this antifibrillar antibody in AL amyloidosis setting. Another option is the previously called NeoD-001, now called Daratumumab. We all know the history about NeoD-001 that demonstrated heart and renal responses in the phase 1 and 2 studies. But we all know the negative subsequent results of the so-called VITAL and PRONTO clinical trials. We know that a post-hoc analysis showed a benefit in a small subset of patients with really advanced disease. And so Dr. Gertz will show us in a poster session the rationale for the use of the so-called AFFIRM-AL clinical trial, phase 3 clinical trial, that will still explore the role of Daratumumab in AL amyloidosis setting. And so we will see in the future the results of this study. Another option is Doxycycline. We know from studies in vitro that doxycycline could have a role on the amyloid fibers, reduces fibril deposition in mouse models, and also we know that from a couple of retrospective studies that it could reduce the mortality post-autologous stem cell transplant in the Alchemy registry from the London researcher. Unfortunately, a recently important study published by a Chinese group reported negative results about the use of doxycycline in combination with cyclophosphamide, bortezomib, and dexamethasone in a phase 3 clinical trial. So, in particularly in terms of progression-free survival. So, we have probably to wait the results of the still ongoing clinical trial here in Europe in order to confirm the role of doxycycline. Other possible options, other emerging therapies should be the light chain stabilizers. We hear at this symposium about the drugs about ATTR amyloidosis. We have now several options, and probably some of those important strategies could be used, could be modified, obviously, but the same rationale could be used for light chain amyloidosis in order to probably stabilize the light chain. But we need specific targets, and we need to study better the targets for the light chain. And several studies are underway, and we will have 3 abstracts. We are having 3 abstracts about a specific target of the light chain here at this ASH meeting. So those new emerging therapies will probably have a role in the future in the AL amyloidosis field. So, in conclusion, what's the best time to start a second-line regimen or subsequent line regimen still remain an open question, and I really hope that the amyloid community will join in order to decide and define the new progression criteria. Because we have now really several treatment options for second and subsequent line. Daratumumab could be considered as the preferred line in those patients who did not receive this drug first line. Immunomodulatory agents, lenalidomide or pomalidomide, are playing a real pivotal role in second line as a second line option, and also could be combined with daratumumab with good results. We can still consider autologous stem cell transplant as a possible option, of course. But we have also now to consider the real important role of newer anti-plasma cell agents that could induce rapid and deep hematologic responses. But obviously, we have to wait the results of all the ongoing clinical trials. The clinical trials are mandatory in order to confirm the role of the antifibrillar therapies. So this will be really important for the amyloid community. And also, we will have to explore the role of the so-called light chain stabilizer. With that, I think that international collaborations for sponsor, but also for investigator-initiated trial, is really a key point in the amyloid field. With that, again, I would like to thank Professor Zonner, the organizer, and also my mentors and my colleagues from the Pavia unit.